Thank you very much, Christina, for the introduction. Ladies and gentlemen, indeed, the question is, what is evidence-based practice and what is it not? And I'm building further on what Gary just has been saying. I do not have a conflict of interest. However, I'm open for any suggestions, so feel free to contact me afterwards. Yeah. Why to talk about evidence-based medicine? Is this needed today? We are already talking about this for 20 years. Well, may I remind you that we are living in a world of fake news and alternative facts. We do not want that this is getting its way to our work, to our field, to clinical practice. So yes, indeed, we need to talk about evidence-based medicine. Another reason why this is important is that a part of the people here in the room are working as researchers. And another part of the people are working mainly as clinicians. And we know that both groups of people quite often look from a different perspective to the same phenomenon. Researchers are looking from a research point of view, clinicians from the practice point of view. And this also results in the fact that sometimes certain thoughts, certain reflections are coming up. Researchers sometimes are wondering, I found these brilliant study results. Why are the nurses and the physicians and so on, why aren't they implementing this into day-to-day practice? On the other hand, the clinicians think, oh, this may sound nice in theory, but I'm dealing with the real problems in day-to-day practice. So this is not implementable in my situation. So we clearly see a gap between practice and research. And in such a situation, it is important that we have persons or systems that can bridge this gap. Evidence-based practice is one method to bridge this gap. The question then is, how big is this gap? And in the early 1990s, Bostrom and Weiss stipulated that the time period between generating new knowledge and implementing this into clinical practice takes 10 to 15 years. Some years later, Landrum indicated that it takes 8, even up to 30 years. So this is a huge time lag between generating the knowledge and implementing this in practice. This has to do with studies in the field of nursing. However, it's not going better in our fellow physicians. In 2011, Morris found that on average, in medicine, it takes 17 years, this knowledge versus implementation gap. So yes, indeed, there is a gap, and the gap is substantial and takes more than 1 decade. Why should this be a problem? Why should we worry about this? And by extension, why do we think that evidence-based medicine could be a solution for this? Well, if you look at all the care needs that are coming to us, all the needs that patients express or all the needs that patients have, without evidence-based medicine, we know that about 30 to 40% of the care that is provided is not according to the evidence. This is a loss of time and a loss of energy. In addition, it is also known that 20 to 25% of the care is unnecessary or even harmful. And once again, this is a loss of time and energy. So if we take these figures together, we can conclude that without evidence-based healthcare, only 1/3 of what we do, or only 1/3 of all the care needs, are dealt with in an appropriate way. So this is clearly a sign that there is room for improvement. So if you ask again, why should we implement evidence-based practice, you can also wonder what happens if we don't, and the answer you could find in the previous slides. May I introduce you to David Sackett. He was a professor in epidemiology in McMaster's University in Canada, and he is one of the founding fathers of evidence-based medicine. And he defined evidence-based medicine as the integration of best research evidence with clinical experience and patient values. So it's these three elements that are needed for evidence-based practice. After a while, the term medicine was questioned and was changed into practice. The definition, however, remained the same. Evidence-based practice is the integration of best research evidence with clinical experience and patient values. Evidence-based practice, in other words, is the combination of these three things: external evidence, clinical expertise, and patient values. And you need to have all three in combination with each other and integrated to each other to talk about evidence-based practice. I'm sure that you, as I do as well, sometimes hear people, colleagues, administrators, whatever, saying like, yeah, but we are doing evidence-based practice because we are following the literature and we are implementing the newest studies that are coming out. This on its own is not evidence-based practice. The same is true by a statement of, well, our nurses are well educated. They know what they do. They are very much updated on the current status and the state of the art. This is not evidence-based practice. And once again, the same, if you only listen to your patients, not taking the other elements into consideration, this is not evidence-based practice. But of course, how to do this? Well, evidence-based practice can be undertaken using 5 steps. And Gary was already referring to these steps. These 5 steps can also refer to the 5 A's. And the 5 A's stand for ask. This is formulating an answerable clinical question. Access, track down the best evidence. Appraise the evidence for its validity and usefulness. Apply, which means integrate the results with your clinical expertise and your patient values and the local conditions. And finally, assess, which means evaluate the effectiveness of the process. Let's have a closer look at each of them. You are working as a nurse in clinical practice. You are standing next to a patient and all of a sudden you got a burning question. Then you have to translate this into an answerable clinical question. And for this, you can use PICO. PICO stands for population, intervention, comparison, and outcome. An example, are patients after an aortic valve replacement benefiting from a 24/7 telephone support compared to the usual hospital discharge in terms of preventing readmissions? These are the 4 elements of the PICO. PICO is typically developed to answer effectiveness questions, where you are looking at intervention studies. Therefore, you can use the PICO. However, also when you have more kind of a qualitative question, a PICO can be used. But then PICO stands for population, phenomena of interest, and context. You've got your question, then you have to track down the best evidence. And first of all, I need to say, Google is not a synonym of research. So don't just go to Google and track down some of the information, because you can find a lot of crap on Google as well. Use the proper sources, and there are a lot of databases available, such as PubMed, Scopus, Embase, CINAHL, Web of Science, and so on. This is the kind of databases, or in these databases you can find primary studies, you can find reviews, you can find an overview of what is available in the scientific literature. However, not everything that is published in the scientific literature is also reliable. So this means that you need to appraise the evidence for its validity and its usefulness. And doing so, we are quite often using this pyramid of the levels of evidence. And below, at the lowest level, you have editorials, expert opinions, case studies, and so on. Valuable to a certain extent, but of course the strength of this kind of evidence is much lower than what you can expect from other levels of evidence that are higher located on this pyramid. And indeed, on the top of this pyramid, you can find systematic reviews and meta-analysis. And preferably, these systematic reviews and meta-analysis are translated into guidelines. I would strongly advocate to look at systematic reviews if you are appraising the evidence. And the reason why I say so is that one swallow does not make a summer. You may find one particular study that is indicated certain results, but you are also facing the risk that the subsequent studies in this matter do not confirm the findings of the very first study. And if you are changing your practice based on this one study, you're probably doing the wrong thing. And I'd like to give an example in this matter. In the University of Leuven, we have a very strong research group on translational medicine and intensive care medicine. And they are really world leaders in trying to find ways to optimize outcomes in critical care patients. And in the end of the 90s, they were doing some big trials, well conducted, nothing to say about that. And these trials were looking at the effect of tight glycemic control in critical care patients and looked at the outcomes. The studies that have been done in Leuven all showed that there was a reduced mortality. This resulted in a worldwide implementation of tight glycemic control. And you see this on this figure. Over the years, so in 2001, the first study was published, and over the years, more and more centers were adopting the system of tight glycemic control. However, the subsequent studies conducted in other centers, multi-center studies, even studies conducted in several continents, did not confirm the initial Leuven findings. The NICE sugar study published in 2008 is one example of it. A huge study with hundreds and hundreds of critical care units all over the globe. And they found opposite results. Tight glycemic control is detrimental for the patients and is associated with a higher mortality. But what happens? Still, there is an increase in the number of centers that adopt the initial thoughts of having good outcomes. So, what does this mean for us as nurses and allied professions? You should not change your practice based on one or a few studies. We all know that adoption is difficult, but also realize that de-adoption is as difficult. And therefore, it is better to wait until you have certainty of the research findings. That's why it is preferred to lean on systematic reviews instead of isolated studies. Once again, systematic reviews are preferred. Another way to deal with this is to look at what is called filtered information. I was referring to the different databases earlier on in this presentation. There are some organizations who take up the job of filtering all the information that is provided by these databases to do the appraisal instead of asking you to do the appraisal, and to combine all this information in other databases. And examples of this are Dynamet, the Joanna Briggs Institute, Cochrane, the NICE Guidelines, the National Guideline Clearinghouse. And in fact, this is the preferable source of information for a busy clinician who does not have the time and or the skills to do the search on your own and to do the critical appraisal on your own. So if you are in shortage of time, then you better rely on this kind of sources instead of the primary sources that I was referring to earlier on. Step 4, apply. That's probably the most difficult thing. How can you integrate these results with your clinical expertise and the patient values and your local conditions? Especially listen to your patients. It is useless to try to adopt or implement an intervention, a strategy that is not acceptable by your patients. It will not work, it will not be effective at all. Also look at the local organization, the local circumstances, look what is possible in your situation. And I'd like to illustrate this with a nice systematic review and meta-analysis published in the Journal of Clinical Nursing some years ago. This was a systematic review on the effectiveness of nurse-led early discharge planning programs for hospital inpatients with chronic disease or rehabilitation needs. And the main findings of this review was that using such a discharge planning program results in a reduced hospital readmission, reduced length of stay of the readmission, and a reduced all-cause mortality. So immediately you would say, yes, we have to do this. But the question is this also possible? Because implementing a thing like this, you need to have a workforce to do so. And from the work of Linda Aiken, we know that there is a huge variability in the workforce. For instance, in Norway, again, the data from Aiken shows that there is 1 nurse on average per 5 patients. In Sweden, there is 1 nurse per 8 patients. In Belgium, there is 1 nurse per 11 patients. You can imagine that implementing whatever new intervention will be more challenging in Belgium than in Norway, just because of the lack of people to take this up, and the higher need to set priorities in this matter. So the local organization cannot be neglected in deciding on the implementation of the evidence. So the final step of the 5 steps is evaluate the effectiveness of the process. Indeed, look closely at what happened in my situation, what happened in the organization, what happened with the patients that we are caring for. 5 steps, that's something that you have to remind, the 5 A's. But how to implement this, how to use this, how to do this? Well, there are a lot of toolboxes available. And I would like to raise some attention for the Joanna Briggs Institute, because this is an institute based in Australia that is really developing tools for clinicians, for nurses, for allied professions, to help them to translate the evidence into their practice. And they have developed specific tools for each of the 5 steps. So if you're wondering, how can I come to a research question? Well, in this toolbox you can find some help to do this. If you're wondering, what is the latest evidence on this question? Well, there are search engines available by Joanna Briggs. How to implement this into my clinical practice? Again, there are tools available at Joanna Briggs. So I would really recommend to have a closer look at the website indicated below this slide. This will be really instrumental for using and implementing evidence-based practice. Let's come to the conclusion of this presentation. Evidence-based practice bridges the gap between research and practice. We know that there is a gap, and the gap really lasts for more than a decade. Evidence-based practice integrates the best scientific evidence with clinical experience and patient values. All 3 components are as critical to talk about evidence-based practice. It comprises 5 steps, as you remember from this talk. And also remember, don't rely on one or a few studies, because you might end up in changing your practice for the wrong reason. Preferably use filtered information and apply evidence-based practice tools. And of course, the patient's voice in this entire process is very important. Listen to your patients and also look at your local context. Thank you very much.